I think one of the issues, and we've had problems with this for quite a long time in follicular, is that moving novel agents into the front line is potentially, I don't want to use the word dangerous, but what you don't want to do is take a drug with unknown side effect profile in that setting and expose them to a group of patients who may be cured with standard therapy.
You used the C word.
I do think that
I trained you well.
Yes, I do think there are a percentage of patients, unfortunately today it's still a minority of patients, that probably are cured with frontline chemoimmunotherapy and follicular.
Do you agree?
There are some long-term survivors, as for sure. Maybe cured, I don't know, it's possibly, unless we do this, as you mentioned before, circulating tumor DNA and look for these, it's hard to tell, but there are some long-term. But back to your questions, and I see your concern, but we cannot extrapolate from the idelalisib into the copanlisib because it's given on a weekly basis where you have a peak and then the drug clears. So this is not continuous level of a drug in the blood forever. So this is, we have to keep an open mind on this drug may be different in terms of safety. But yes, the trials and upfront has to be monitored very carefully, make sure that this will not happen to otherwise a patient who would, destined to live for a long time. But I think the only way we can improve the cure rate for follicular lymphomas is to improve on the treatment outcome of frontline. So the reason why watch and wait or delay treatment make no difference is because what we have is a lousy treatment. Yeah. Otherwise, it would have made a difference, right? So unless you improve on the regimen, I think we'll not be able to make an impact on patients' cure.
I totally agree. I think, and all of us have worked on frontline regimens using kind of novel agents in follicular. And truly, I think the way we are going to cure these patients is some combination of novels. But I think, at least in my own world, until we have long-term follow-up of drugs like this, I'm still a little hesitant to move them into the front line.
But we've done that. You and I have both moved R squared into the front line. And we did that based on, there wasn't a lot of data. There was our CLGB data at the time, but we both did it. And the results were kind of spectacular. So let's create the scenario here. Based on the data that you've published and Peter Martin from our group has published, the response rates with R squared up front are in the range of kind of 95%, with CRs around 80 plus or minus 5. If the relevance trial, which was R squared versus R chemo, favors R squared, with those kind of data, which is unlikely because phase 2 data are never the same in phase 3, but even if they're close, where can we go from there?
I think that, again, going back to cure, although the response rates are very, very high with that regimen and as you mentioned, in multiple phase 2 trials, we still see a percentage of patients that relapse. And we've seen that now with longer follow-up that both Peter and I have presented at the last Lugano meeting. We still see probably, if you're looking at about 4 or 5 years, 30% of patients are still relapsing, 30 to 40%
so
of patients.
So beyond the magical 2-year mark.
Yeah, the late relapses. So I think that I'm hopeful with the new, with the data that will be coming out from the relevant study that we're going to see a group of patients that are doing better than our chemo. But I think that it's not curative in everyone yet. And so I think we're going to have to focus on increasing the percentage of patients that truly get long-term remission or potentially cure. And it goes back to, I think, what Anas mentioned earlier, newer techniques at surveying very low levels of tumor in patients, whether that's circulating tumor DNA or assays looking at very low levels of progenitor cells, or how we're going to move the field forward. So I agree, the old standard design of looking at a drug in combination or as a single agent using overall response rate and maybe even PFS is probably becoming to an end. And we're going to have to develop newer biomarkers to truly assess which patients are cured or which patients have no more detectable DNA.
Now, a couple of years ago, we all went to these NCI working group committee things. And you and I were follicular, you were probably in Hodgkin's. And the follicular came up with a study design where patients with early relapse were going to be randomized to O-CHOP for obinutuzumab, O-umbralisib or TGR-1202, or O-lenalidomide. And so they're focusing on these early relapse patients and doing a bunch of molecular stuff. Do you think that's the correct approach?
It's a good approach. I mean, it's not a wrong approach. You have to work with what you have, and at that time, that's what we had. Well, that's what we knew. I think there's multiple ways to skin a cat, and this is one of them. And then looking at different regimens and see which one the winner, sort of pick the winner. I forgot the design, whether it was like multi-arm in the same trial. These are separate cohorts. Yeah.
Multi-arm.
Right. Yeah. So you can pick the winner and see.
But they're focusing on the early relapse patients.
Well, I mean, that's a good question. So, I mean, is this going to hold? I don't know. I mean, you've seen the data, and now it's coming in from the R-squared in patients who had early relapse, and they're not doing as bad as we thought. Same thing with idelalisib, even though, patients who had early progression with single agent oral PI3 kinase inhibitor, they're not doing as bad as we thought. So, based on what we knew at that time, everybody freaked out that if you progress within 2 years, your survival is impacted. Whether this data is going to hold as we introduce more agents, I don't know.
Yeah, my concern was we're focusing all the national resources on relapse patients and not on where I think.
Yeah, but the readout faster, right? So if you want to test new agents, see what's their potential before you move them up front, the readout is faster for relapse patients. So it wouldn't be wrong to test these agents in relapse setting, but that should not be the end point. The end point should move them up front. I agree with you.
Right.